Okay, so this is your GU lecture for class 12. So we're going to talk about some different diagnostic studies. First, review some basic anatomy, talk about some reasons for renal failure, and lastly with kidney transplant. So the urinary system, this process starts in the kidneys, the nephrons, the tubules, the loops, the glomerulus. Remember that stuff from A&P. These are where the whole process starts and takes place, and the main goal is to filter the blood to maintain our homeostasis. So remember, the body's always trying to keep things in balance, and the kidneys do that with a lot of different chemicals, which we'll get into in a bit. So erythropoietin. Erythropoietin is produced where? It stimulates red blood cells in the bone marrow. Okay, so it starts the production of red blood cells. The kidneys also activate vitamin D, and they produce and secrete renin. And renin regulates what? The blood pressure, and it's produced in the juxtaglomerular cells in response to decreased perfusion, decreased arterial blood pressure, decreased serum sodium, increased urine sodium, and activates angiotensin, and then angiotensin 1 is converted to angiotensin 2 by ACE, and that's where ACE inhibitors work. That's angiotensin converting enzyme. So now you know what that means when you see those drugs. Angiotensin 2 stimulates aldosterone from the adrenal cortex, and then that leads to sodium and water retention. Okay, so that is the deal with renin. Prostaglandins. Then prostaglandins, they happen in response to pain, and they vasodilate. So here's a picture of the functional unit of the kidney, the nephron. So we've got the glomerulus, and that does selective filtration. The proximal tubule, remember the difference with distal and proximal. So the proximal is going to be closer to the start point. Reabsorbs about 80% of your electrolytes and water. All this is on the next slide, so you don't need to write this down. Reabsorbs glucose, amino acids, bicarbonate, secretes hydrogen ions, and creatinine. And then the loop of Henle, that's the loop down there at the bottom, reabsorbs sodium and chloride in the ascending limb, and reabsorption of water in the descending loop. Concentration of filtrates. And then the distal tubule secretes potassium, hydrogen, ammonia, and reabsorbs water. And then the collecting duct is where the resorption of water takes place, most of it. Okay, so that's talking about that. So from each kidney, a ureter leads to the bladder. These work through peristalsis to have one-way flow, so we normally do not get urine backing up into the kidney. They're smooth muscle, and it's longitudinal and circular in the ureter. So then that leads to the bladder. Our normal output is about 1,500 milliliters a day. Now that's going to vary, of course, with how much you drink and just how the rest of, how your health is. If anything is wrong, it could decrease or increase that. Then from the bladder, we have one urethra, and that's a small muscular tube that leads to the outside. Urethrovesical unit. Okay, this is made of transitional epithelium, or rugae. We talked about rugae in the stomach also. When the bladder fills up, it sends signals to the brain, and we either tense or relax to hold our urine or to void. So when we have problems in the brain or spinal cord, that can affect the bladder. Also, some diseases can affect it too. So there's just your basic anatomy picture of what we just talked about. Two kidneys, each one with the ureter to the bladder to the urethra. Oh, back up to this one. So with the bladder filling, When it reaches about 200 to 250 mils, we start to feel the urge to void. When it gets to 400 to 600, we're getting uncomfortable. And then 600 to 1,000 is our normal maximum capacity for people. Okay, so that's just an indication of about how much is in each void. So our physical assessment, subjective data. We're going to ask the patient if they feel distended. Ask them when they've last peed or voided. You're going to palpate, inspect, percuss, and listen. And then there just tells a little bit more about each one of those there. Some terms for the urinary system problems that we might have. We've probably talked about all of these before, just to review there. One that is not listed there is pyuria, and that would be like pus or white blood cells in the urine. So let's talk about some diagnostic studies. First we have a urinalysis, and this is just a basic test. This is usually the first thing done to obtain a baseline and to see where they're at, if they have anything out of whack in there with the electrolytes or any blood cells present. So it's a routine collection, can be any time of day. We're usually going to give them a little towelette to wipe off with before, but it doesn't have to be, super clean. It's not a clean catch or anything. And it needs to be refrigerated and examined within 1 hour of collection. And then a urine culture and sensitivity, or CNS you'll hear it called. This is the clean catch, so it's caught midstream. So you begin to urinate into the toilet a little bit and then catch it after the first little bit comes out. And that's just to allow the first few mils to flush out any bacteria that might be along the surface of the urethra or the outside genitals. So clean catch, start, catch it, and then finish in the toilet. And they're going to use this to detect UTIs. And the culture and sensitivity means they're going to do a culture of it and find out what kind of bugs are growing in there, what kind of bacteria you have, and then the sensitivity determines what kind of antibiotics it's going to be sensitive to, so they know how to treat it. Composite urine collection, this is going to be over a period of time, and it can be anywhere from 2 to 24 hours, and it will need to be refrigerated. And then there's a 24-hour urine collection for creatinine clearance. This is a 24-hour collection. So how this goes is you discard the first specimen, and then you start going into this jar, this big container, and you do it for 24 hours, can't miss one. If you miss one, you have to start over again. And then you keep the last void. So you discard the first one, keep the last one at the 24-hour mark, and then they're going to run tests for creatinine clearance. And there's a formula there that figures that out. The normal is about 85 to 135 milliliters per minute. Okay, next we have the concentration test. So think really hard about making urine. Now, if you're dehydrated, what's your concentration of your urine going to be like? It's going to be up or down? It's going to be up. It's going to be very concentrated if you're dehydrated. Okay. So to do this, they're going to have them be MPO, and then they collect 3 specimens an hour apart. Urine cytology. This is a clean catch, and this is where they're going to look for evidence of cancer or abnormal cells from the bladder or the structures, the urethra perhaps. Residual urine. This is going to determine how much urine is left in the bladder after someone urinates. So you've probably already done this in the clinical setting, where you do a bladder scan. We don't want to just jump to the catheterization like it says here. If it's me, I'd like you to scan me before you catheterize me, please. The scan, the ultrasound will tell how much fluid is remaining. And the normal finding would be less than 50, but as you've probably seen in clinical, when somebody's had a catheter taken out, they tend to get some urinary retention, and so they're going to end up having more left behind in there. And this is especially going to be true with men who've had TURPs. They've had surgery in there. It's going to be a while before they're able to urinate normally, and sometimes it seems like the doctors, in their rush to get them out of the hospital, they seem to take the Foley out too soon. I think most nurses would agree with that, because the patients end up with a lot of residual urine, and then they can't go home because they can't pee. Protein determination. This is the dipstick. I don't know if you guys did this in first semester, but you have these little sticks with different colors, and you stick it in the urine, and then it tells you what kind of things are in there. Is there sugar? Is there protein? Are there any blood cells? So we don't want protein in the urine. So it should be 0 to trace amounts. Okay. But the dipstick is the simple test for that. Okay, some other diagnostic studies talking about the blood. BUN and creatinine. You hear these always together. BUN is the concentration of urea in the blood, and normal there is about 10 to 30. And creatinine is the end product of muscle breakdown, so that's also going to tell you how well your kidneys are working. The BUN to creatinine ratio, normal should be like 10 to 1. Don't get excited if it's 11 to 1 or something like that. It's in a normal person, it's going to be around that ratio. When it's going to be out of whack, it's going to be way out of whack. Like it might be 10 to 4 or something like that. So use some common sense when you're interpreting labs. Here's just some normal blood values. You've already seen all of these before, I'm sure. And then we'll move into radiological studies. KUB, you'll hear this ordered, and that's an X-ray. It stands for kidneys, ureters, and bladder. So all it is an abdominal pelvic X-ray. And they may order a bowel prep for this, because if there are contents in the colon is in front of the kidneys and the bladder, so it may block it. So they probably will have to do a bowel prep here. IVP, intravenous pyelogram, and that's an X-ray of the urinary tract after they inject contrast material into the veins. What do we have to ask before we ever do that? If they're allergic to iodine or shellfish. And patients who have problems with their kidneys should not probably receive this, because it can be nephrotoxic. Sometimes they still have to, there's no way around it sometimes. So they'll give them some drugs to help clear the kidneys. Acetylcysteine is a drug that they give. And prep, so we're going to want to empty the bowel again there at 8 hours NPO. They do need to be consented before we do a dye, so they'll need to sign for that. And we also want to tell them that they're going to feel warm. They may feel flushed and salty. They may taste saltiness during the injection. So it's a good thing to teach them that, because otherwise, if you push something and then they all of a sudden get really hot, they're going to freak out that they're getting an adverse reaction. So always warn somebody when you know that there's a side effect that they're going to receive. And then afterwards, we want to push fluids to help flush that contrast out. We want to get that out of the kidneys so they don't have problems. Then we have antegrade pyelogram and retrograde pyelogram. You can read more about these, but they're similar, but the dye is injected directly into the kidney, into the renal pelvis usually, and then they see where it travels. So the picture there, you can see it in the renal pelvis go into the ureters, and it'll go on then to the bladder. Cystoscopy. Some of you may have seen this if you traveled to the OR. This is where they put a scope into the urethra, and they use this to see what's going on in there. If there's a bleed, they need to cauterize. If there's stones, they want to see what kind of stones, how big they are, if they can get them out. So anytime they need to go inside there and take a look, they're going to put this flexible scope into the urethra, and they can go all the way through, through the urethra, into the bladder, all the way up the ureters. These scopes are really long, so they can go all the way up to the renal pelvis. And you can see and you can flush things out, and sometimes they have, they can cauterize, or they can grasp little stones and pull them out. So cystoscopy is an OR procedure, so they will be sedated, and so therefore they'll need to be 8 hours NPO. They will have to do a consent, and they're going to be put up in the stirrups. So an important thing we need to remember here is when they come down from the stirrups, we want to take the legs down together gently and slowly, and that requires 2 people. It's not good on your back if you try to take both legs of somebody down out of the stirrups. And the reason we want to do it gently and slowly is because there's a risk for hypertension. So that's what the hypotension, rather, I'm sorry, as the blood rushes back to the legs. So that's what the scope looks like there. And the little port here is going to be connected to a camera, to a monitor. There is a camera inside there. So it's going to be connected to a monitor. So it's not like the doctor's looking through his eye at this little piece here. It's going to be projected up on a big, HD screen so you can see the inside of everything very clearly. Okay, some other diagnostics, renal ultrasound, that's self-explanatory. MRI, everybody knows what that is, and we know that if we have pacemakers or metal inside, we cannot use that. CT scan, same kind of idea, we know about that. Assess for iodine sensitivity again. And make sure that the lab values are on the charts before that, because the physician's going to want to see that their blood and creatinine are relatively normal or stable. A renal arteriogram or angiography. And this is where they're going to put a catheter in the femoral artery, so in the groin. They're going to pass it up to the aorta, the abdominal aorta, so in the abdomen area, up to the level of where the renal arteries are. And then they're going to shoot some contrast in there. And that's going to help them see the difference, if it's is it a cyst, is it a tumor, what's going on in there in that area. They'll also do this to do a workup for a donor who's going to donate their kidney. They just want to go in there and see that everything is good, all those arteries are open and clear, and that they're, these are going to be good kidneys to transplant into somebody. So again, we have the dye, assess for an allergy, going to do the consent, going to have the blood and creatinine on the chart. Post-op, whenever we're going into the femoral artery, that is a large vessel. So what do you think is going to be the big precaution? Bleeding. Yeah, so we need a pressure dressing on there, and then it's going to need to be assessed very frequently to make sure that there isn't any bleeding there. And when we have a large wound like that, you don't just look at the dressing or around the dressing for bleeding. You want to also look underneath, because pooling could exist. It could be dripping and it's pooling underneath them, or also assess the tissue underneath there too, because it could be pooling on the inside. So we want to make sure that the back of the thigh is not all boggy or getting bruised or looking like it's full of blood. So we need to be very aware of bleeding when a large vessel like that is pierced. Potential complications, allergic reactions, renal damage, vascular complications, just talked about. So that's what it looks like when they shoot the dye in there and it goes all through the kidney. And it kind of looks like a tree if you turn it on its side. Looks like a pretty autumn tree. So, okay, we just talked about that. Signs and symptoms of problems. And then, so this is how it goes in. So this is your femoral artery. Goes up in there to where it branches off from the abdominal aorta, and then it goes up into one kidney or the other. Here's some other tests here we're not really going to talk about. You can read about them. Some of them evaluate the muscle tone, if someone's going to feel their bladder being full or not. It can look at the amount or degree of obstruction that they might have. Are they getting nervous stimulation? What happens when the bladder gets full? That kind of thing. So you can read up on those. Not that important. Now remember, you will cover renal failure in a lot more detail in 220. So this is just kind of an overview. So GFR, what's that stand for? Glomerular filtration rate. And the normal should be about 125 mils per minute. And that is reflected by the urine creatinine clearance. That's why we do that test. So end-stage renal disease is diagnosed when the GFR is less than 15. So that's quite a difference, right? It goes down from 125 to 15. And there's degrees of renal failure. So look how sad she is. She has chronic uremia. This just talks about the different things in organs that is going to be affected by renal failure. So you can take a minute and look over that chart. So the most noticeable change is going to be to the skin, and this is known as a uremic frost. So it's dry, pale, itchy, kind of gray, frosty looking. Okay. So when somebody has uremic frost, we need to be concerned with nail care. Make sure their nails are short and that their hands are clean, because they're going to itch. And so if they itch and they have nails and they scratch something open, hands are dirty, they're already immunocompromised because of their sickness, it could get real bad real fast. So that's just something simple that a nurse can do, is take care of their nails. There's some bad bruising that might occur. Some other problems with the reproductive system might occur. Nutrition. Now, generally, with a few exceptions, when someone has kidney trouble, we're going to restrict protein. Okay, so with chronic kidney disease, we're going to have them have 0.6 to 0.8 grams per kilogram of body weight per day. They're also going to have a water restriction. The intake is going to depend on how much they're putting out. Okay, so that's not something that's standardized across the board, but just be aware there probably will be a protein restriction and a water restriction. Okay, and this is another reason of why when somebody rings their call light and it's not your patient, you don't go in and just fill up their water jug because they asked you to. Right? We have to know what's going on with them. It could really do some damage. Also, sodium restriction. Pretty much everybody should be on a sodium restriction. There's way too much sodium in the American diet. So they got to be instructed to avoid high sodium foods and not use salt substitutes, because salt and sodium are not exactly the same, and also salt substitutes have a lot of potassium. And when someone's kidneys are messed up, guess what? We don't want them having a lot of potassium either, because potassium is one of the electrolytes that's excreted by the kidneys, and if the kidneys are messed up, they're not going to excrete the potassium. So we want them to have about 2 to 4 grams per day. So here's an example of some high potassium foods. Those are all really good foods for most people. This is what we should prescribe for most people, but not for kidney people. Also, we want to restrict phosphate, and phosphate is going to be in foods that we know have calcium, so a lot of your dairy products. So watch out for that. So we want to look out for signs and symptoms of fluid overload, so fluid volume excess, we know about that, right? And hyperkalemia, so be aware of our electrolyte disturbances. And we want to tell them to be very careful to adhere to their diet. But if they're in this situation, it's quite possibly due to diabetes, obesity, high blood pressure. So they probably aren't the best people at adhering to a diet if they've gotten to this point. Just saying. All right, let's talk about kidney transplant. The latest figures I could find were from 2009, and in this country there was 17,736 kidneys transplanted, and almost half of them were from living donors now. So there's almost 72,000 people on the waiting list, or there were at the end of 2009, so that was a few years ago, but it's probably not getting any better. This is a good website here. It has a lot of interesting stats and links to tell you more about it. So if you're interested in kidney transplantation, look that up and do some exploring on there. This is showing how the number of transplants has generally been going up. There was a little dip there in 2008, it looks like, but it's on the way back up again. An example to show you how things have gotten worse. In 1980, The deaths from end-stage renal disease were 10,478. So 10,000. In 2009, it was 90,118. Okay, so we've got a lot of problems in this country with obesity and diabetes, and those are the big killers of the kidneys. So as you can see from this chart, it is just going up and getting worse. So the 1 year survival rate is extremely good. 90% for cadaver transplants, 95% for live donor transplants. So if you're lucky enough to get a kidney, and you're not one of those 72,000 people still on the waiting list, when you get a kidney, you have a really good shot at a 1 year survival rate. It's not as good looking further, but even three years is a good rate. It has a good rate too. Well, the advantage of kidney transplant, a big one, is no more dialysis. So that's something. Those people are chained to that machine 3 or 4 times a week for a few hours. It really impacts your life. After the first year, they basically break even. It's way less expensive to do a transplant than it is to do dialysis. So after having a transplant for 1 year, they've already broken even. So, who can receive a kidney? Well, they want the kidney to go to someone who is going to get good use of it. Okay, so younger people are going to be a little higher on the priority list. Someone who doesn't have a lot of comorbidities. Probably not to an alcoholic unless they're famous and have a lot of money. So they want to make sure that it's not going to go to waste, right? Live donors, as I said, have become a lot more popular. A lot more people are doing it. I actually tried to do it about 10 years ago, and I started going through the process, and then I eventually was not able to. But they take it out laparoscopically, generally, so it's just a small cut along the side. This is how the body is positioned. They put a few ports in there, and they go in on the flank, and they take it out. So here's a link to a video you can take a look at here. This takes about 3 hours. They may need to remove or break some ribs to get it out of there. And they're going to start this procedure an hour or two before the recipient surgery is started. So they're going to take the donor in there first and get started on that, and then they're not going to bring the recipient in until they know they've got the kidney out and it's good, and then they can move on and get the recipient in there and put it in. So when they do put it in, this is how it goes. They leave the old kidney in there, and they put it in below it, and they reconnect the arteries and veins to it, or well, they don't reconnect it, they connect it because it wasn't in there before. So they make sure it has good circulation going in and out, and it just hangs out there. Okay, this is just talking about how they're going to put it in antibiotics to keep it clean. And this talks about the arteries and veins that they're using. So they clamp everything off, and then they sew them together. So they do these anastomoses, and then after everything is complete, they're going to release the clamps one at a time and just check them, make sure that the blood is flowing good and there's no leakage. If there is any leakage, if it's small, they can put some gel foam on it or something to stop the bleeding, but they may have to put a few more sutures in it. But once everything is unclamped and the blood flow is reestablished, then they're going to start making urine. They may give them a diuretic to speed that process along and just make sure that it's working. And once it starts working and urine has been, it starts to flowing, it's good. They're done. Now, this is a video that I really want you to watch. Watch this whole thing, so you can pause me now and do it, or open this up in another browser, come back to it later, but I really want you to watch this video. This is a 60-person transplant chain. So how this works is this, and this is what I was working on doing a few years ago, is that I didn't have anybody specific that I wanted to give a kidney to. I was just going to donate it. And so what that would do, it would go to Joe Smith over here, who needs a kidney. He has a sister, Jenny Smith, who wants to donate to him, but they're not a match. So I give mine to Joe, and Jenny is still willing to donate, so she gives hers to somebody else named Bob, and Bob has a wife who is going to donate, and so she gives hers to someone else, and so on and so on. So watch this chain. This was at the time the biggest transplant chain. It's a nice story, so definitely give that a look. So it's a really nice thing. 60 lives were affected, and here they all are. So post-operative care for the donor, it's going to be similar to laparoscopic nephrectomy. That's pretty much what it is. So they've taken out the kidney. They're going to have little flank pain, small incision, and we're going to need to monitor their renal function, monitor their hematocrit. They're going to have daily labs at least once a day, and monitor their urine flow. The post-op care for the recipient. So this is a little bit of a bigger surgery than it is for the donor. They're going to start putting out a lot of urine right away, and there's a few reasons for that. This other kidney is going to be really good at making urine, right? And the kidneys that they have are not so good. So they haven't been making a lot of urine, and now all of a sudden they're going to. They've also been given a lot of fluids during the operation, just like any other surgery, and they may have been given diuretics too, like I said. And then initially the renal tubules may just be a little bit confused about what's going on there. So urine output is going to have to be replaced milliliter by milliliter every hour. So do you think we're going to very carefully monitor the urine with the kidney recipient? Yes. Okay, if tubular necrosis is occurring, they may have to go back on dialysis. We don't want that. Rejection, this is the biggest problem with any transplant. So the kidney matching, it's not quite the same as blood donation matching. With the blood types, there's only a few of them, and the matching is very specific. With kidneys, it's a much more complex process. So there's several points that need to match, and it's nearly impossible to get a complete match. So what they do is they find someone who is as close as possible from the donor pool, and then they treat them with immunosuppressants to suppress that immune response, that rejection that the body is trying to do. Okay, there's a foreign object that's been put into my body, and the body doesn't know that it's supposed to be there, so it starts to fight it. So they give them immunosuppressants to suppress that reaction. This can occur immediately, or it can occur over time. They will have to be on immunosuppressants for life. So, all the problems that are going to come from that too. They can't really be around anybody that's sick. It's dangerous to be in public places, around a lot of people. So, wound infections can also occur, and that's, not going to be made any better by the immunosuppressants. So it can occur from the incision, IV lines, drains that they're going to have in there, or they could get a pneumonia if they're not using their IS and getting up and walking. So this is a big problem that recipients face. Another sad thing is that they can have a recurrence of the original problem. So they might end up having glomerular nephritis, they could have nephropathy, they probably still have diabetes, right? So problems are going to still happen from that, or the kidney could get sclerosed. So unfortunately, getting a kidney transplant is not just the end, the happy ending, and everything's groovy. They may end up needing a second one, so then they have to go back on that list and go through the whole process again. So kidney transplantation is a great thing, but it's not the happy ending that everybody was hoping for necessarily. So we want to encourage them to accept that they have this chronic disease and it needs to be managed. So they really need to be very careful about what they eat. They got to maintain their ideal body weight. They probably have to lose weight initially. Keep them free from infection. So keep them away from groups of kids and large crowds and things like that. And whenever anybody has a cold, don't hang out with them. They're going to need to have regular blood work to make sure all their levels are within acceptable ranges. So this is something that they take into account when they're deciding who to give the kidney to. Is this somebody who cares about their health and they're not smoking and they're not drinking and they're not 400 pounds and they're going to do what it takes to keep this kidney? Because if not, I've got a 14-year-old kid here who's in really good shape and through no fault of his own he needs a kidney too, so I'm going to give it to him. Okay, so it's very important that they evaluate that the people are able to do what they need to do to make the operation a success. All right, and that is it for class 12.